Perfect. Can you see my screen share? Perfect.
Yeah, it's visible. Your screen is visible now. We can hear you. You're audible. Perfect.
Writings on the screen are also visible. Perfect. Okay, so thank you everyone. I see some familiar faces here and some who have joined for the first time. So thank you for first having this topic, because this is something which is very close to my heart. Veneers and laminates. Let's call it smile designing. You may call it so a smile design can comprise a lot of things. You can have composites there. You can have indirects, and in indirects you can have veneers. You can have laminates. You can have full crowns. So ultimately, today's topic that I will be dealing with is how do you get indirect veneers into this aspect of smile design, or how do you do smile design using veneers and laminates, as we like to call it. So two things that I would want to take you through is first, disperse the dogmas behind veneers and laminates. So in an hour and a half, I can tell you what veneers and laminates can actually do, and then what's the reality and what you should be looking at when you're looking at veneers and laminates. This is my CV, if you might like to call it, but thank you so much for that introduction, Dr. Sudhir. It is great to be here and great to have an audience like this. For me, the most important tool in my hand is those two things. You can look at either having a microscope or at least having a loop. Trust me, dentistry without a loop should be banned. Nobody should be doing dentistry without having a basic loop. If you do not have a loop, you cannot distinguish anything less than 0.2 mm. It's not visible to the naked eye. When you cannot see it, you will not be able to treat it. When you do not treat it, it will lie there as a space. It could be a place where leakage is happening from. It could be a place that starts secondary caries, and there could be multiple problems. So what is the most important part is you being able to see, because I am sure we all are good enough after we see something to treat. We have additional tools that can help us, but magnification is irreplaceable in dentistry. And most common question, if I'm buying a loop, which one do I buy? You buy a 3.5x loop, minimum. We used to say a 2.5x, which is the starting range, but frankly, after say using a 2.5x loop for around 3 months, you will realize that magnification is just not enough. It feels like I've been doing dentistry like this only. So it is minimum that you go to a 3.5x. So start with a 3.5x. You do not want to spend on 2 good loops. There's no point in spending money on buying equipment. So start directly with a 3.5x, and it might take a little time with the 3.5x, but frankly, if there is something that you can take back from today and learn, is first thing, go and order your loop. And when I say good loop, please do not buy those Chinese loops. These are nothing else but magnification lenses, and what you will have are headaches. You will buy the loop, you will have headaches, you will throw them away. You need to buy good quality loops, because a loop is not just about magnification, it's also about handling different things inside. It's about handling your magnification to look to you, for you to look proper. It's about handling something called as aberration. An aberration could be a spherical aberration, it could be a chromatic aberration. I'm not getting into that, but a good quality loop, if you look into the loop light, if this is the loop that's happening, there will be lenses fitted inside at different angles. These lenses are precisely there to manage those aberrations. And that is why buy good quality loops and do not buy the Chinese ones, because I know of people who bought the local loops, and I can understand that you're trying to save money, but what will you do in saving money for your eyes? Using those Chinese loops, you will have an increased eyesight if you continuously use them. Second, the biggest problem that I find with those Chinese loops is the fact that you start to get headaches. You will not use it for more than half an hour to an hour. You will just throw them away. So if I were to suggest a few companies, first thing, this is called a flip up loop, which the loop can be flipped up. When you are not working with it, you can just flip it up. And this is called a TTL, which is a through the lens. So this is fixed. The lenses in the middle are fixed, and this is according to your IPD or interpupillary distance. So the company will come, they will take your IPD measurement and they will also take your working length measurement. Working length is from where you are sitting and where you are working comfortably. So they take the IPD and they take the approximate working length, and then the loop is manufactured for you. Now, the difference, flip up can be used by multiple individuals. So if you are having a practice where you, your husband, your spouse, or there are multiple people who are going to use that loop, then you prefer a flip up loop. The flip side is that it will be heavy. The flip up loop will be heavy. Whereas a TTL is basically made for you. It's a customized loop. So the moment you wear a TTL, it will be lighter in weight because there are no expensive mechanisms there. It is lighter. And second, it's easier to adjust to a TTL loop. But the flip side, slightly expensive, and you will be the only person who can use them. And you will be the only person who will be using that loop. Eventually, if you are looking at ergonomics and the best possible way to work, you should be moving to a microscope. There is no other go. The only place where you will sit straight and work down is a microscope. I have tried the ergo loops, the loops which have come now, but trust me, they don't even come close to the microscope. They are good in what they are trying to project, but they don't even come close to the microscope. Now, if you are looking at good qualities, so if you're looking at flip up, there are only two companies that I can recommend, either Hein or Zeiss. Only two companies that I will recommend. If you're looking at TTL, if you're looking at a very price affording range as an entry level, you can go for Zoomax. If you're looking, this will be around 40K. If I'm not very bad at this, this will be around 40K. The next you could look at Admitech, which is the next and good level, that will be around 70 to 90K. But if you are ready to go that extra mile and buy really good flip up loops, you could be looking at Univet, which starts from 1.2 for those flip ups. So Zeiss unfortunately doesn't make flip up loops, but if they would, I would be the first person to buy a Zeiss flip up loop. Zeiss unfortunately doesn't make a flip up loop, but Univet goes from 1.2 onwards, and Univet is good. The other company that has just come in India is Designs for Vision, which is also really good, but then again, cost is at the range of Univet somewhere there. So look at service, look at those guys giving you a demo loop. If they are not able to give you demo loop, please do not buy them. Because if you don't look and feel into that loop, you will never be able to buy it. And if you are the only person, like I said, TTL is your choice. At least a 3.2x, which will become 3.5 for the flip up. So it's a 3.2x minimum that you would want to buy. Now, today, the topic is basically adhesive dentistry. And when we speak of adhesive dentistry, we are speaking of enamel only. We are not speaking of anything else when we are speaking of adhesive dentistry. 1 second. Okay. So when we speak of adhesive dentistry, then you are speaking about enamel preferably, because all the studies that have been done till now, and especially with the anteriors, when the veneers were bonded to enamel, the success rate over a 12-year period was greater than 95%. The moment they got into dentine, the moment you went more into dentine, the failure rates increased. So what does this prove? That the only bonding that you can actually trust till date, and that stays put over a period of time. So I can show you bonding to dentine which goes up to 40 to 50 megapascals. Using the right bonding methods, you have very high bond strength. But the problem is, once the bond strength comes into function, once there are matrix metalloproteinases that get released, the resin dentine bonds will disintegrate over a period of time. They do not remain stable. They will do not remain stable. But with enamel, it's like a simple human being. It's very simple. It bonds and it stays the same way. The reason there is no water or less water in enamel. Second, the prismatic structure is such that once you have bonding, it's almost permanent, and it is very difficult to break the enamel bonds with respect to adhesive dentistry. And that's why your orthodontists can suspend heavy loads. Once they just bond those brackets onto little enamel spaces, they can suspend wires, they can pull the teeth in, pull the teeth out, intrusion works, everything can be done. That's because bonding to enamel is the most important thing. So from today, your second take back would be to preserve enamel. Remember when we have those repeat crowns that we are doing, the crowns that we placed around 20 years back. So some of the senior dentists did that. But when you remove the crown, you see the crown was hardly prepped. There was hardly any prep to those crowns. They would just create spillway spaces interdentally and put a crown on top, which would be bulky, accepted, but the patient would slowly get adjusted to it because they would reduce it occlusally like a table. Now, what are we doing? The moment we take away the enamel from there, and if you closely look at what is left, you will see a lot of enamel. The moment you take away that enamel, you are dooming it to failure. That's why the same patient will keep coming back to you and telling the crown gets dislodged. If I look at the dislodged crowns that I get normally, 99% of them will only have dentine, nothing else. They will be bonded, supposedly bonded to dentine. And what do you go on doing? You call the representative and say, yeah, I believe the GIC doesn't work this time. Let's find a new cement. And what he will do, he will send a resin modified GIC to you. Stays put for 3 months. The crown again dislodges. You call him again. Arey yaar, ye bar RMGIC bhi nahi tika. Do we have something else? And yes, he'll say, I have a resin cement now that I will send to you, and you can bond it with that resin cement. Trust me, guys, resin doesn't bond to dentine unless you make it bond to dentine. You will need to follow adhesive protocol. The only thing that can bond as a true bond to dentine in dentistry is this material called as GIC. It is still the best material if you are looking to bond to dentine. The only problem with GIC, it is soluble. So GICs will fail inside out. They will fail from they will fail outside, and I'm sorry, they will fail from around and then they come inside, because the last bond to fail on a GIC would be a dentine bond. Whereas a resin will fail inside out. The first bonding that will fail on the resin is the dentine bonding. And then eventually enamel bonding if enamel is left. Now, if there is no enamel on your tooth surface, what will a resin cement do bonding there? It will eventually break down. Next up, if you are looking at any bonding procedure, you are looking at a strict isolation. Isolation from saliva, isolation from blood, and isolation from GCF. 3 things that can be detrimental to your bonding are saliva, blood, and gingival crevicular fluid. So unless you have a proper rubber dam in place, trust me, all these 3 are variables. They cannot be controlled. And when you have more number of variables, there are more chances of failures. So the only answer to all these 3 variables is putting a nice rubber dam. If you do not know how to put a rubber dam, learn. It's not rocket science. I started using the rubber dam from 2013 onwards, and trust me, there was nobody to teach me. We started taking models, started looking at videos wherever I could find them. Today, you have enough information over the internet. You have enough courses that happen. Please join in the nearest course. It's a 1-day program. Rubber dam, get the hang of those basics. Go back and put it in the mouth of your patient. Try it on your assistants first. Try it on your associates. Be confident enough to put it in the patient's mouth. Once you are able to put the rubber dam, trust me, all the slipshot methods in dentistry will go out. No cotton rolls, no cotton that is stuffed here and there, nothing. You just have one piece of rubber that can isolate almost all the fluids, and you are working happily. You can in fact use it for further retraction also. That's how a rubber dam works. The most difficult step to do anything is to start. Like I said, you will find the first few cases of your rubber dam to be the most difficult. In fact, the first 10 cases that I put a rubber dam, I inevitably tore my rubber dam. The first 3 cases where I did a root canal, I almost perforated them, and 2 of them were actually perforated. But I don't give up. The most difficult step was to start. So even with an indirect veneer case, the most difficult step is to start. Trust me, I will show you the prep during the live demo. To prep for a veneer is very easy. If you've been doing preps for a crown, preps for a veneer are I mean, like pocket change. But the most important fact in when you do a veneer is to plan your case, because these are high level aesthetic works. When your patient is going to pay you that X amount that you are going to charge him in doing a veneer, he expects results. And now, see, imagine you're going to buy a car. What would you look at? You would look at the specifications first. You would look at the engine. You will look at the everything else, and then you will finally decide on the color. And before you go in to buy a car, you've actually pictured yourself driving that car, or you've taken a test drive to see how it feels. Similarly, for the patient, you are the only person they are trusting with their smile. And trust me, it can go wrong badly if you do not know how to plan your case. So the most difficult step in probably doing a veneer is to plan a veneer treatment. Everything else will fall into place. Everything else is straightforward and it shall fall into place. Now, veneers can be of two types. They can be direct veneers, where you use composite and you put it inside the mouth after you've prepped the tooth to a certain extent, or probably no prep. It totally depends on case to case. And then it can be indirect veneers. When we say indirect veneers, you prep a tooth, you make an impression, you send it to the lab then pours the model, does a die cut, prepares these thin shells of porcelain for you, sends it back. You will use a particular protocol to bond it onto the tooth. Trust me, bond it onto the tooth. Now, veneers can never be luted, so you cannot use GIC for veneers. You will have to use a veneer cement, and we will come to this. You will have to use a particular veneer cement to bond your veneers. That's what are indirect. So indirect is always a staged approach where you do the prep today, and today with CEREC or whatever, you will still need a different appointment or an appointment at a later time where the patient comes back onto the chair and you are fitting the indirect veneers. Now, frankly, veneers and laminates are, if you look at the definitions and stuff, all that is there, but they are used interchangeably. But if you look at the thinnest difference is the laminate maintains color and usually it does not require any prep. Whereas veneer can change a color and also change the structure overall of a tooth. That's the mild difference between a laminate and a veneer. It's like putting a veneer on wood versus putting decolam on wood. Decolam is a laminate, whereas veneer jiske upar polish hota hai, it's a veneer. So a veneer can actually change the final texture, whereas laminate maintains the color and cannot change the texture too much. Indications. Now, when I say indications, these are interchangeably used. I mean, you call it porcelain, laminate, veneer, frankly. So it doesn't make a difference. Either a veneer or laminate, that is case dependent. Indications for both are, can we have the mute, please, everyone on mute?
So, kayo facing check, Who catch what's the boil is name?
Sorry to interrupt, Dr. Pratiek. What is happening? You know, whoever is joining new, those are only on.
So you can mute everyone.
I'm taking
okay
care
once
of
they
it.
join.
Really sorry
No
for
problem.
inconvenience.
No problem.
Muting everyone. Don't worry.
Yes. So in discolored cases, like in case of tetracycline stains, in case of fluorosis, in case of devitalized teeth. When I say devitalized teeth, teeth which have been root canal treated. Today, we believe that doing a crown for an anterior and a root canal is an overkill. You don't need a crown unless you've lost all enamel. If there is enamel, please preserve the enamel and put a veneer on top. I can show you studies which prove that reinforcing a tooth with a veneer increases the flexural strength of the tooth much beyond than the original tooth itself. A chipped off and fractured teeth, obviously when you have chipped off teeth, say a patient comes in with an Ellis class 2 fracture and wants a permanent or a solution that will last him for a long time, veneer is your option. You do not need to look at composites, which could be a temporary option. So a composite is never a permanent restoration, frankly. When I say permanent, I'm speaking of beyond 5 years minimum, if not more, because the patient will expect at least 50 years. But you at least think practically and think of at least 5 years. Everything else is a temporary restoration, which is less than 5 years, or a semi-permanent restoration. If you have rotated or malaligned teeth, you can obviously do veneers, but only if these are very mild rotations and malalignment, which is not big. But if you have a bigger malalignment and teeth which are rotated very much, then it is better that you look at orthodontics. Short teeth which may require lengthening, you could be looking at you could be looking at teeth which have patients which have a gummy smile with altered passive eruption. All those are your ideal patients. Teeth with spacing, diastemas, arch-length tooth material discrepancy, post-ortho. Now, these are your ideal patients to start off with your veneer. So if I had to pick a case and do a veneer on it, if I had to pick my first case, I would pick a case with spacing. Probably one of the most easiest cases, but I have to plan the case well. The planning of the case requires high level of importance. Now, contraindications. When I say contraindications, these are frankly only relative contraindications. Every one of these can be managed. So actually speaking, there is no true contraindication to doing a veneer. You can do it in every case, provided you manage the cause. Now, teeth with lack of enamel, say you have greater than 50% of bonding surface in dentine, more than 50% in dentine, it's always better you cover it up with a full crown and give it a retentive space. So in that case, probably the only where I would accept that doing a veneer would not be the better option. You can do a full crown, but even then you can do something called as immediate dentine sealing today. Seal the dentine surfaces, allow the bond strengths to develop to the bond strength of enamel, and then do your prep and bond it. So even IDS is possible. Crowding in severely deformed teeth. So you might do orthodontics first, not to be taken up directly to do a veneer right now, but you can obviously do orthodontics first and then come back and obviously do veneers if needed. Patients with habitual clenching, grinding, and say brushing habits, which are very hard. Even in these, if you can manage the cause, you can do veneers. Today, we do full mouth rehab with only tabletops in the posterior and veneers in the anterior most. You do not need to be worried about clenching, grinding if you can manage the habit. Again, non-occlusion, non-ideal occlusion, where you have an edge-to-edge bite. For an edge-to-edge bite, if you can do, say, orthodontics or put the patient through clear aligners, get the bite corrected, you can obviously do the correction of the occlusion also. And then veneers would be a possibility. Like I said, any of these, pick up periodontal disease. If you can manage the disease, you can do a veneer also. Teeth with large pre-existing restorations and high caries risk patients, even these, you can manage them first, get the caries risk down, and then you can look at bonding. So all of these, frankly, are relative contraindications. That means they cannot be done right at the moment, but if you are able to manage all this, you can definitely do a veneer in those cases also. Now, at present, 3 indirect veneer systems are available for you, which is one, the conventional veneers that you generally send to the lab and the lab makes it for the patient. Second are indirect resin veneers, which are usually CAD-CAM. They come as CAD-CAM blocks and they are CAD-CAM and sent back to you. These are basically composite, indirect composites. For the patient who right now cannot afford the cost of a veneer, you can have a low cost option with indirect composites. And the third option would be lumineers, which are ready-made veneers made of porcelain called as serenade porcelain, which is specially made for these. Now they are ready-made. You will need to custom fit it in the patient. So you check which fits and then you fit it back. Today, I shall be speaking about indirect ceramic veneers only. Now, if you look at the conventional veneers or ceramic veneers, your material options available. Now, these are material options for ceramics or material options for non-metals. If you are looking at no metal, or if you are not looking at the metal ceramic, the conventional metal ceramics, you have glass-based ceramics, which is feldspathic porcelain, lucite, and lithium disilicate. You have alumina-based ceramics like Inceram alumina, Inceram spinel, and Inceram zirconia, or you have zirconia-based ceramics. Number 2 and number 3, you cannot do veneers with them because both of these are metal oxides. Alumina and zirconia both are metal oxides, and when you have a metal oxide, you cannot etch it. If you cannot etch it with hydrofluoric acid, as we will see in the protocol, you cannot bond it to the tooth. The only 3 material options truly available to you today are either feldspathic porcelain, lucite, or lithium disilicate. Let's look at the 3 one by one quickly. Like I said, another classification where you can call it glass ceramics where feldspathic, which are just true glass ceramics. That means they are basically sand mixed in water. Let's put it that way. They are basically true glass ceramics with sand mixed with water. Then you have glass ceramics with fillers. To a glass ceramic, if you have fillers added, I'm explaining this in a very layman language, but to the glass ceramic, if you have fillers added, they are called glass ceramics with fillers. That means you still have a glass matrix in both of these. You still have a glass matrix. So whenever you have a glass matrix, you can etch it. To etch glass, we use hydrofluoric acid, HF. So you can use hydrofluoric acid and you can etch glass. Once the glass is etched, you can silanate the glass and bond to it. You can silane and then add bond to it. Now, when you look at glass-free ceramics like alumina or zirconia, again, both of these cannot be bonded. Since they cannot be etched, they cannot be bonded. True bonding to zirconia, my friends, doesn't happen. I am not dealing with zirconia bonding here, but zirconia doesn't bond to the tooth structure. True bonding doesn't happen with zirconia. Now, if you look at glass-based ceramics, because only these can be used, the first option that you had or have still are feldspathic, but unfortunately, this is no longer used. Two reasons: it requires the technician's skill, and if you have a very good technician, they can actually do a good feldspathic porcelain. And second is strength. The strength is very less when you are looking at feldspathic porcelain. Now, to this feldspathic porcelain, if you add a filler called as lucite, it becomes lucite porcelain. When you add a filler, you add strength. When you add a filler, you add strength to it. And that's why you have lucite porcelain, which has high strength, higher than feldspathic, and this can be used for veneers. The advantage with lucite is the overall, so the overall flexural strength and the overall aesthetics are as good as enamel. If you can see the picture there, that's the veneer bonded. But if you see the overall outlook, it looks like the tooth itself. So the physical properties were as good as enamel. And that's why this is still a hot favorite material if you are doing veneers. In fact, I do a lot of veneers with lucite, and the trade name is called as Empress, IPS Empress. So you can look at good labs who have these Empress, and trust me, you can do veneers and they will look natural and lifelike. The third and the most commonly used material for doing veneers is lithium disilicate, which we commonly know as Emax. Emax is frankly a trade name of lithium disilicate, which was copyrighted by Ivoclar. Ivoclar, the company has a copyright, and that was called as Emax. Now the copyright is no longer there over the molecule, and there are other companies also who are making molecules with lithium disilicate. Similar, Dentsply is coming up with a material called as Tessera, which is reinforced lithium disilicate. So lithium disilicate with higher strength. And you have GC, who makes GC initial, which is also lithium disilicate as a molecule. Now, what's the difference between lithium disilicate and lucite is when you take feldspathic porcelain and you add a molecule called as lithium disilicate. So lithium disilicate is basically the filler that was added. If you add a filler called as lithium disilicate, the end result is called as a lithium disilicate porcelain. That is what we use as Emax. Now, the advantage with this is the material has a lot of strength, 70% filler. So the more the filler, the higher the strength. But at 70%, why did they stop? Is because the properties also need to be managed. Otherwise, if you add beyond 70%, it becomes a little more opaque. You do not have properties as good as natural enamel, which you eventually want. Now, because of the favorable translucency and variety of shades that are possible, it can be used as fully monolithic and also as CAD-CAM with the ability to be stained and glazed. So you can use it both as a veneer and as a full crown also. You cannot do a full crown. So there were full crowns done with IPS Empress also, that means lucite, but they did not last because the strength was not good enough. But with lithium disilicate, you can do both a veneer and a full crown also. And the fact that the material can be either CAD-CAM or pressed. I'm not going to get into details of what is a press versus what is a CAD-CAM, but this material can be CAD/CAM or it can be pressed. It can be cut back and layered. So there are multiple options with one single material, and that's why this is the hot favorite material of doing, say, a veneer, or even when you are doing a full crown in the anteriors. So the examples, like I said, are Emax. So let's stop calling it Emax. Start calling it lithium disilicate as a molecule. And then you understand that Emax is from Bioclear. You can have other companies also that are making similar, like GC Initial, Emax CAD, and Vintage from Shofu. Also now you will have Tessera there, which is the new thing in the market from Dentsply. Now this is how lithium disilicate are given as something called as ingots. These ingots are put in a pressed machine or a pressable machine, and they are pressed onto the substrate. Let's not get into the details, but that's how lithium disilicate is made. Now, if you look at the flexural strength of lithium disilicate, or the fracture strength, versus zirconium oxide, which is layered zirconium oxide, it is layered by conventional ceramics. So the zirconium, the base has very high strength, but if you look at the layering ceramics, the strength is too less. And now if you look at the strength, compressive strength of enamel, it's about 384 megapascal, which is ideally the same as your Emax. That's why it is said that the best material to replace enamel is Emax. The best material to do veneers today would be Emax or Lucite. Now, there were zirconia veneers that came up in the market, but frankly, it just went away because the biggest problem is there. Zirconia cannot be chemically treated. So it cannot be treated with hydrofluoric acid. You will not get the etching pattern where the resin would go and bond. So if you do not bond, it will debond. And although you have zirconia bonding by using the SAC protocol, my sound is not clear, just check. So if you can still bond to zirconia using the SAC protocol, the SAC protocol is sandblast, adhesive primer, and resin cement. You can actually bond using the SAC protocol, but frankly, the bond strengths are not great enough to be used at veneer. We discuss about the SAC protocol not later here, but in our full program whenever we do it. Then you have indirect resin veneers that can be done. When you speak of indirect resin, they are basically, I've just given a trade name there, Lava Ultimate. You also have Vita Dynamic, which are available, but then just to give you a trade name, Lava Ultimate is from 3M. And it is basically your Z350 composite, which was injection molded into a block. And that block now can be CAD/CAM. So this shows that the injection molded composite has high strength and it can be used as CAD/CAM. That forms the basis of the Bioclear method, frankly. So you get a flexural strength of about 200 megapascal, which is good enough for a veneer, and you have excellent resiliency. The biggest advantage I see in doing veneers with composites or doing anything with indirect composites is the fact that it is repairable. If you have a chip that happens, you can easily repair that chip. So repairability is one of the biggest advantages when you use composite indirect, and also the cost, obviously. Now, if you look at steps in doing a conventional veneer fabrication, let's just quickly, the first step that you will do is smile analysis. So without analyzing the smile, you cannot do smile designing, right? So you will need to sit and analyze the smile. To do that, it is always done with photos, videos, and the patient's casts. I see a lot of people messaging me on social media, on phones, and send me these photos of the patient, send me some videos of the patient, and say, sir, can you analyze the smile and let us know what can be done. Without the patient's cast, frankly, the analysis is always half done. I do not know what it is like in the mouth. So at least take good photos, videos, and patient's cast, and now mount those casts. You don't need a phase bore transfer and a semi-adjustable articulator. At least mount them in a basic 3-point articulator, or give it to the lab. They will mount it in a dog bite. Now you can sit and analyze a lot of things. A good quality impression, my friends, is very important. You could take it with alginate or with silicon, and always take a bite and mount it. See, there is so much of information that you can get from a good cast. If you look at just this, there is a missing tooth there. There is a retained canine. Is it a deciduous canine now? There is a malpost canine. So where is the lateral there? A lot of questions that can be answered by looking at a simple cast. Also, what you can look at is the arch form. What the arch form tells you is whether if I am doing a veneer, this will be an additive case versus I will have to subtract that much. It's a subtractive case. So a lot of things, a lot of information that a good cast can give. Now, speaking of photos and videos, ideally follow the AACD protocol to take the photos and videos. You can go on their website and they have a PDF that you can download. But if you are not following the protocols, the minimal that you will need is a full frontal face, a face with a smile, one with cheek retractors and then the patient smiling, and a bird eye view or a 12 o'clock view, because that tells you if the upper teeth are in alignment with the lower lip line. Also, optional could be taking the profile views, the lips at rest, and informal speech. Now, speech is very important, especially the phonetics video, when you ask the patient to make particular sounds to understand whether you will lengthen the central incisor or you will need to intrude the central incisor, or if the central incisor is at the apt place. Now, if you have to increase the length, the only place you can go is gingivally. So you will have to do gingivoplasty or gingivectomy. All of that can only be informed or got after you have good photos, good videos, and then the patient's cast. In the intraoral pics, you need a full arch upper, a full arch lower, anterior shots which are from canine to canine, and patient in occlusion. Optional pics could be upper and lower anteriors with contrasters and a 12 o'clock view. You can take a screenshot of this. Now the new protocol includes taking videos of the same rather than taking photos for just 10 seconds, small 10-second videos. At the end, I will play those 10-second videos, and those 10-second videos, trust me, any camera that you have today, any mobile phone camera, is minimum 30 frames per second. So in 10 seconds, you are recording 300 images. If you cannot get it right in 300 images, you cannot get it right in the next 3000 also. So it's easier to take a video and then take a screenshot from there. If you look at extraoral shots, these are very important, where you're taking the patient's profile with the patient smile and then with the cheek retractor. This is according to your DSD protocol. And this is the 12 o'clock view, where you see how the central incisors or all the anterior teeth are in alignment with the lip also. One of the photos, the other with a lip cheek, and that's a smile. And the fourth is a 12 o'clock view. So these 4 views is what you will need definitely. If you look at the intraoral shots, you take the full arch, you take the anterior shot, one in bite and one with the teeth slightly separated. When you separate the teeth, you can see the translucency. That's the advantage. Teeth slightly separated, and then you can have the patient smile. Also, you can have the bite on both the sides. So the new protocol, like I said, tells you to take about 10 seconds videos, and it will be videos like this where the patient is standing and just patient is in front of you and you are taking those videos with your mobile phone. You do not need to take these videos with a DSLR or a particular a specially made camera. You can just do it with your regular mobile phone, because this is for you to sit and analyze. Now, if you look at the 12 o'clock view and why I stress on it, if you look at this case, this is mostly a reductive case. In fact, this patient would ideally go for orthodontics first. Get the teeth into alignment and then you can look at doing veneers. Whereas if you look at the second case that I'm going to show, this one, this is mostly an additive case. So start off with additive cases. Why do I speak so much about additive and not reductive? Because when you reduce, you might take away enamel. And if you take away enamel, the veneers will debond. Additive, you are looking to retain as much enamel as you can, and you are mostly going to do additive procedures. Now, you can have your digital treatment planning. I use the DSD software to do my digital treatment. I also use the DTS Pro software. Please take a look into both of these softwares. The DTS Pro is much more simpler, easier to use, and also affordable. So you can use the DTS Pro or DSD, plan your treatment, and then communicate to the lab. So this is how we do it in the DSD, where we take the patient's smile, analyze it. Now the smile is projected. So now I understand this is the amount of length I can increase, and this is the amount of height I want. Accordingly, there are templates present which it gives you the ideal proportion, and that tells you how much height can be raised within gingivally and incisally. Look at that. And you have a scale that is customized according to the patient. So I can send all this to the lab. Now the lab understands that I want a wax up, which will increase 1 mm there and about 1 mm on the incisal. They will send me a wax up with the exact dimensions. Once the lab sends me a wax up, I will transfer the wax up into the patient's mouth without prepping the teeth using a material called as Protem. You don't prep the teeth. You take the wax up, you make a putty index like this. I will show you it during the demo. You make a putty index like this. You transfer it into the patient's mouth without prepping teeth. Now show them the smile. This is called as a test drive. It's like test driving a car. The patient now looks at their smile and test drives. So they see how it looks according to the face. You take the photos and you go ahead and show it to the patient. So this is the information to the lab. All details are sent to the lab, and also the cast photos. So if you look at this case, like I said, how much of importance your cast is: additive, 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 slightly additive, slightly additive in the distal, additive. So mostly this case is an additive case. I do not need to do any subtraction. No subtraction is necessary. That means I do not even need to touch tooth structure. I have enough tooth structure to just go ahead and bond my veneer. Isn't that an advantage? Because you are bonding totally to enamel. Again, you select the length, you select the shape of teeth with something called as smile analysis that you do. You send it to the lab, use a concept called as visagism. We teach in detail about these concepts during our programs. So you decide the type of the teeth and then you send it to the lab. Once the lab now sends you something called as the wax up. Wax up is nothing else but ask the lab to do a additive wax up in white wax. Additive wax up in white wax. Please do not ask for a reductive wax up, because in a reductive wax up, the lab will prep the teeth. I don't want them to do it, because I want to show this inside the patient's mouth. Now, all those pictures along with the dimensions are sent to the lab. And you ask them to give you a non-prep wax up. Now it is returned to the clinic. It will be something like that. Ask the lab always to duplicate the cast. Duplicate and wax up. So they will duplicate the cast, wax it up, send it to you. Now you make a putty index, something like this. You take a putty, put it onto the teeth. I will show you how to make the putty index. You make the putty index. Now, this putty index, you transfer Protem and directly transfer it into the patient's mouth. Look at that. The patient can see how his future smile can be. These little extensions, you can take it off with a BP blade. So the patient can actually gauge how his smile would be after your treatment is done. And trust me, the patient is sold 99% of the times here. The only 1% that go back is on the basis of your cost. But 99% of the patients are just sold here, seeing the wax up, seeing the transfer in their mouth. They say, just go ahead and prep. Don't waste time. Start prepping the teeth right away. So you should be ready on the day of the wax up with everything. If the patient stays prep, go ahead and prep. And take photos, take videos, take your consent, go ahead and prep the teeth. Look at that. The only change that this patient wanted was me to just slightly decrease the length of the canine there. Okay, do it. Just go ahead and do the prep. Also inform the lab about this change so that at the end, you and the lab are working in the same harmonious integrity. So you do not have the lab who's working at a different direction. Inform the lab that this is the change that you want. Again, photos can work a beautiful way. You take these photos, send it to the lab also, and tell the lab that is where that slight change the patient wanted. Just make just that. The lab can again take an index of the putty of the wax up that they've done, and they can transfer it for the final also. So you will not have changes from the before to the after. And when you do a wax up also, take videos. Take videos just to see how it looks when the patient is doing his or her phonetics. Take videos like this. So the patient does the similar video that we've done previously with all the phonetic sounds, the M, the F, the V, and then you look at the B's, you look at all these sound and you look at the video. So to understand what you've done is perfect. Next, once this is done, let's look at the type of veneer preparations that can happen. There are basically three types of veneer preps. One is a window preparation. That means it will just end there. It will be like a window on the facial surface. It will not move on to the incisal edge. There is no involvement of the incisal edge. In the second, you have a butt joint. This is called a butt joint. That's a veneer prep that extends to the butt joint. And in the third, you have an incisal overlap. That means you will also go on to the palatal or the lingual surfaces. In the first, you are only confining yourself to the facial surface. So your prep is like that, just confining yourself to the facial surface. That's it. It's like a window, as you can understand. In the second, the butt joint, this is the most common type and the most accepted type. Why? Too little time to explain. I shall explain that in the future sometime. But butt joint is the most common and the most accepted design. One, because of its horizontal placement, path of insertion is straightforward. And second, you do not have a palatal edge because there the ceramic is thin and it can chip. So the beveled incisal edge or the butt joint. And the third, which goes on to the palatal surface, is called an incisal overlap or wraparound type. This is a window prep. This is the most preferred type for direct composite veneers mostly. Okay. It can also be done in cases of fluorosis where you feel the contacts are good and you don't have to alter anything. Preparation extends out to the incisal edge but doesn't alter it. It is also preferred design in veneers and premolars where you're just looking to extend the smile into the corners. Second is a butt joint type of a prep, which I said involves the incisal edge but doesn't go onto the palatal surface. Maximum usage of the incisal edge or also maximum usage of the enamel present there. Second, the incisal edge is reduced by at least 1.5 mm. This allows for ceramic thickness and also allows for the lab to have enough room on the incisal edge to give you the incisal translucency, to give you the cutback, and the lab needs that space for the ceramic. Okay, this is the most common prep. And type 3 is a incisal overlap, which is no longer preferred. You would just prefer the first or the second. So second followed by the first. And finally, in some cases where you don't have any option, say you already have a veneer or you already have an existing restoration that goes onto the palatal surface, then you have no options, but that's the last when you will go on to the incisal overlap. Or say the patient comes in with a fractured tooth, Ellis class 2 fracture, and there is no enamel, so the fracture is oblique. So the fracture extends into the palatal segment, then unfortunately you will have to go slightly palatally and grab the palatal like an overlap. That's the least preferred, but yes, that can also be done. Now there is something called as the APT technique that I told I will speak of. Imagine you do the test drive. Now that test drive, according to DSD and all other softwares that you've used, is actually the final outlook of the patient. So why not prep from there? Remember the case that I showed you? I told you this is mostly an additive case completely. So now if I put my depth cut at the tooth surface, I will end up removing enamel. Why not put it directly onto the test drive? So look at this case. Patient comes in with spacing. This is her mock-up. This is how her teeth will look, about 99%. This is 95%. This is how her final smile would look. Why not start putting my depth cuts from here? So when I start putting my depth cuts from here, I have enough room for the veneer, which is about 0.5 mm on the cervical end, 0.8 mm on the body, and about 1 to 1.5 mm at the incisal edge. So you have enough room and you will be minimal invasive onto the tooth structure. Sometimes you will realize that after prep, you don't have to do anything to the enamel at all. Let's see this case. Those are the depth cuts. And eventually, see how little, just that little amount had to be prepped. That's it. Everything else is perfect. So this case is 100% in enamel. You have preserved enamel to such an extent that you are 100% in enamel. You do not have any damage to the tooth structure. You are 100% in enamel. And now the bonding that will come will be absolutely perfect. So it's all about preserving the enamel. This is the APT technique or the aesthetic pre-evaluative temporary technique given by Dr. Galib Gurel. This is called the APT technique, the aesthetic pre-evaluative temporary, where you pre-evaluated the temporary and now you are prepping through that temporary rather than prepping directly through the tooth. Because if you prep through the tooth, you will end up removing more tooth structure, especially at this cervical end where enamel is very thin. You do not have a lot of enamel thickness there. So to preserve that enamel thickness, you are better off. See, it is hardly any prep there. I have just created a margin for the lab to understand where to stop. Now the steps in preparation would include, if you understand this, and this is an ideal tooth where you have 1 mm at the cervical, but in a clinical condition, you will only have 0.5 mm max at the cervical. So you want to be as minimal invasive to be on enamel in the cervical area also, because that is the area where your veneer will bond. You do not want dentine exposed there because debonding can happen very nicely or very easily there. You have enough at the body where you can reduce 0.8 and at the incisal edge 1 to 1.5 mm, 1.5 mm at the incisal edge. The most important thing at the incisal edge. Now, when I say 1.5 mm, people tell me that you are in dentine here. No, the dentine is surrounded on all sides by enamel and it will be covered entirely. That's what we mean when you do an incisal edge preparation. If you look at minimal thickness of a veneer, you need 0.3 at the cervical third, 0.5 in the middle, and 0.7 at this curvature, at where the tooth is curving. But more than that, you need 1.5 mm of incisal reduction for you to have maximum translucency and enough thickness of the ceramic. So the step 1 would be incisal reduction. We will be doing this very soon. Just ask him to set up the light demo. So step 1 is incisal reduction, where you will use an Sr11 or an Sr12 Bur and sink the entire body. I will show this. Okay. So you will do the incisal reduction first. Then you give the labial depth cuts, which is on the surface of the tooth, and you give it using these burrs. These are the tri-wheel burrs. So if you see the wheel burrs, the depth from this to this, let me put it in a different color. The depth from here to here would be 0.5. So you cannot prep more than 0.5. You cannot prep more than 0.5. You get depth cutters from 0.3, 0.5, and 0.7. I would prefer you having 0.5 and 0.3 only. 0.7 could be an overkill, because anyways, even after 0.5, when you are doing your final finishing, you will prepare a little more tooth structure. Third step would be facial or labial reduction, where all the depth cuts are joined together to create a uniform, even surface. Always maintain the facial contour. You will do a prep into two planes, a biplanar reduction. And in the final, if you are going for a palatal wraparound, then you will wrap around. Otherwise, just finish the incisal edge. Like I said, a wraparound is not preferred because there is a restricted path of insertion. Whereas these two have a simple horizontal path of insertion. In the final one, this little ceramic has a lot of stresses and can chip very easily. Now, speaking about my finish line, where would I want my finish line? As much as possible with the new modern age ceramics, you will remain supra or equigingival only. You will go subgingival only in cases where there is discoloration. When the tooth stump is discolored, you will have to go subgingival to mask the discoloration. Otherwise, please remain supra or equigingival only, because it is easier to maintain easier to clean, and better, easier to polish for the patient, for you to polish and for the patient to maintain also. A rounded 0.3 mm finish line is to be given. You will use a rounded burr. We generally prefer the TR13 burr. I will show you how we use it. The TR13 burr or a TR12 burr can be used to give your final margin. Now, the next thing that you will be doing is something called a gingival retraction. It is usually by a single cord if you have an equigingival margin. If you use a double cord, it will be a subgingival margin. But again, you can also use a double cord for an equigingival margin also if you want further retraction. The whole idea is to record the emergence also when you are sending to the lab. Okay, so which cord to use where? I mean, it's a detailed topic, but in general, 000 or 00 will be your first cord, which will go into the sulcus. The second cord would be a 0 or 1. 000 or first 0, and you will always use one cord at least. Instead of the second cord, you can look at other retraction methods like a retraction paste. Lithium has a very good retraction paste, or you could look at other retraction methods like Extraoral or magic foam. But all of that is only your replacement for your second cord. Your first cord is compulsory, and your first cord is always without astringent. So please buy cords which are non-impregnated. Do not buy impregnated cords. Buy non-impregnated cords. If you need, you will dip it in an astringent and use it. Now, when you are using an astringent, which astringent would you use? Ultradent is the most common astringent followed all over the world. What do they call it? The Ultradent? Viscostat. Sorry for that. The Viscostat is the most common. The brown one or the clear one. Viscostat clear for anteriors. Please use the Viscostat clear. For the posteriors, you can use the brown one. So Ultradent is the most commonly used astringent. Your second cord can be impregnated or should be impregnated, whereas your first cord is never impregnated. I will explain this when I'm doing the prep. It will make it easier. Then your final impressions, always a custom tray is ideally needed. If you do not have a custom tray and you're picking a stock tray, pick a metal stock tray with rim lock. Rim lock metal stock tray is always preferred, and your final impression material should either be an A-silicon or a polyether, nothing else. A-silicon or polyether only. If I am looking at a single step versus two step, single step is followed in cases where there are 1 or 2 veneers. Anything more than that, please prefer a two-step impression. Always better when you are using a two-step impression because you have uniform thickness of light body that flows. And always wait 1 hour before you pour the models. I'm running through this, but yes, we are already beyond time. So you always wait 1 hour before you pour the models. If you're looking to give provisionals, and you should be giving provisionals in these cases, immediate provisionals can be, you can again use the same putty, fill it with Pro-Temp and give it as a mock-up or sorry, as a provisional this time, as a temporary. I just left the material Pro-Temp. You also have Luxa-Temp, which is also very good. If it is 1 or 2 teeth that you are prepping for veneers, you could use direct composite, or you could also use Revotech LC from GC. Spot etch and lube the temps. This is called a spot etch, where you just add one etching at only one spot, add 1 drop of bond, do not cure it, and just put Pro-Temp in place, slap Pro-Temp in place, and it will stay, it will stick onto that. It is easy to remove because it is only bonded at one place, but that one spot edge bonding is enough to retain the Pro-Temp for about 3 to 4 or 7 days till your permanent veneers come down. Lab communication is the most important thing. You always convey the final shade, the type of the prep, and the stump shade. Don't forget to give the lab the stump shade. If you do not give the lab the stump shade, he will not understand what ingot to select. This plays a very important role. So please give the stump shade to the lab, and always follow the PG color chart. If somebody knows about the PG color chart, you always follow my color chart. Send the stump shade of the prep, because he will correct the select the correct ingot and select all the photos and videos that you've taken. Now you've done all this, you've temporized, you've sent the patient, the lab does its job, sends back your veneers. What do? The first step that you do is called as a try-in. Now, try-in is done in two stages. One is individual, and the other is a group try-in. Individual is when you try in each veneer with a dry fit, see if it fits well. Do not put a lot of pressure on the veneer, be very gentle with it. Try in each veneer, see for the marginal fit, done. When you do a group trial, you will either use a try-in paste. Many companies provide with a try-in paste, or use KY jelly. 1 drop of KY jelly so that the veneer sticks in place. Now you put all the 6 or all the 8 or all the 10, whatever your planning is, put it there. See whether they all fit well without hindering each other. Sometimes you realize if you try to fit both, one is getting dislodged. That means there is a high contact interproximally. You might have to slightly trim that using a disc so that now the veneer can seat properly. So once you have a proper seating and your try-in is done, you will now start your final cementation steps. Now these can be divided into two broad categories. One is what you will do on the veneer surface, and the second is what you will do on the tooth surface. Tooth surface, which is inside the mouth, and veneer surface, yani interior surface on the inside of the veneer. The first step is to use hydrofluoric acid on the veneer surface, followed by phosphoric acid, H3PO4. Now, when you use hydrofluoric acid, you either use a 5% or 9%. 5% comes in red, 9% comes in yellow, making it easier for you. So when you use the 5%, on Emax, you use it for 25 seconds. For 5%, 25 seconds, and for 9%, 20 seconds. Do not over etch. Just use it to the apt time. So have a timer in your hand, or today all your phones have a good stop clock. Please use it. So if you are using 5%, 25 seconds, 9%, 20 seconds, do not etch more than that. After that, thoroughly rinse it with water. Once you rinse it with water, you will realize that the veneer has a frosted appearance, something like that. It has a totally frosted appearance. Now, these are also salts present because of what you've done with the etch. There are some salts present, and these need to be removed before you put your silent. To remove this, you will use phosphoric acid or alcohol. Since alcohol, not everyone will be having in the clinic, phosphoric acid is the same etch that you use to etch the teeth. Use it for 30 seconds inside the veneer surface, 30 seconds to a minute, and all those salts that are generated will go away. Just simple. After this, if you look at the steps, hydrofluoric acid, then dry right here I put ethanol, or you can use phosphoric acid there, which is H3PO4, which you commonly use inside your onto etching your teeth, then a silane coupling agent, then a universal bond, and don't cure the bond. Don't cure the bond, because if you cure, it will increase in thickness. You do not want the thickness to increase. Don't cure the bond. And finally, use a light cured veneer cement. Absolutely no cement else, please, for a veneer. Light cured veneer cement only. Either a Calibra veneer or a Reliax veneer from 3M. You can also use the Bioclear Aesthetic, Variolink Aesthetic, which is not N. N has, it's a dual cure. So don't use the dual cure. You will only use completely light cured resin cement only. That's onto the veneer surface. Now keep it aside, keep it hidden under something, because you do not want the bond to start getting cured. Onto the tooth surface. always isolate the tooth surface first. Okay. Isolation can be done, should be done ideally with a rubber dam. Once you've done the tooth surface isolation, you will first clean it using pumice or the blaster. Because it's an enamel, you can use aluminum oxide. You can use aluminum oxide over it and just blast the surface so as to remove any debris, any contaminants, and any leftover temporary cement. So you've just used the temporary cement or that bond. You do not want it to stay there because that can also act like a hindrance and you might crack a veneer from them. And then you etch the tooth surface using phosphoric acid, apply a layer of bond, and it is optional to light cure. Even if you don't light cure, nothing happens. It is optional to light cure. But if you have dentine exposed anywhere along your prep, it is advised to light cure. Anywhere along your prep, it could be in the middle, it could be on the incisal edge, somewhere you find dentine, it is always advised to light cure. Before you light cure, make sure you air dry it very nicely. You do not want it to increase in thickness. And always bond your veneers using a light cured veneer cement only. Completely light cured veneer cement only. I'm stressing on it repeatedly because dual cure cement release tertiary amines, which will discolor at the margins. Patient will come back with marginal discoloration. So you will just use a light cure veneer cement. And yes, you could use heated composite, but that will be a topic for some other day. Initially, please stick to veneer cement because heated composite can be a little tricky to handle. Always apply KY jelly at the margins and light cure nicely. And you will finish and polish the margins using your ceramic finishers or ceramic polishers. Then you will finally, after bonding, check for occlusion. And this is checked by using a 40 micron paper. 40 micron paper. And you can trim it if needed using a red band or a yellow band burr, followed by a brownie point. And finally polishing it using a ceramic polisher. You cannot leave a surface which is rough inside the mouth, especially on a veneer, because it will crack. 40 micron red, 40 micron blue for centric or MIP, and red for eccentric. Okay. Let's finish off with one clinical case before we move on to the demo. Again, I think we have two cases that we are showing here. Slightly flayed out. Again, mock-up. You prep through the mock-up. First, give the incisal preps, and then along the facial surface, prep through the mock-up, and that's the prep done. Again, use the same mock-up or the same index to give your temps. These are spot etch and spot bonded. Spot etch and spot bond your temps. There, the final veneers come, you remove the temps, and that's how it looks. This is, I think, after 4 years. We now have an 8-year follow-up of this patient. Nothing has changed. They absolutely look the same. Once veneers are bonded, they stay bonded forever. Look at that. Absolutely, that's the importance of the 12 o'clock view. See how they are following, see how they are following the lower lip line. Absolutely blending in. And the patient just loves her smile now. Second case, again, failed ortho, or I shouldn't say failed ortho, it's a relapse post ortho where those spacings opened, the patient did not want ortho. You do a quick mock-up, show the patient the mock-up and start prepping through the mock-up. Look at that. All prep, guided preps through the mock-up. You eventually have to remove very little or no tooth structure sometimes. And certain areas we've just done no tooth prep there. This is after removal of the temporaries and once they were blasted. Dry fit. Now look at this. After you etch, you hardly realize that there is that little place where dentine is exposed or that little place where dentine is exposed. But apart from that, 98% of all teeth surface there is on enamel. I am confident now that this will last. You add etch, you add silane. This is immediately post bonding. This is a close-up view. That's the happy smile. Now you see a follow-up after 1 month. Even this little dark triangle that you can see there, the gingiva just creeps in so nicely. Gingiva just fills in so nicely. Just 1 month. Look at that. And now she has a very confident smile from a shy smile that she had. This is after 6 months. We did not get to see her after this. My friends, love what you do and do what you love with passion and commitment. And trust me, doing veneers will not be very difficult. Okay, so I'm sorry, just stretched a little over time. And frankly, it's a very huge topic to cover in an hour. Couple of minutes before I set up my live demo. Any questions that I can take, please? Let me stop the share.
Yeah, we have a lot of questions. Anybody is having question and wants to ask directly, so please raise your hand or you can write it down in the chat box. So first, while you were explaining about the loops, he is asking Zoomax or Admitec, which you prefer, which one dentist should prefer?
So if money is not your concern, then I would look at Admitec because it is slightly better than Zoomax. But if you're looking at an entry-level loop, then Zoomax is good enough.
Another question was there. Many times I get cervical undercut while preparing margins. To remove it, I need to remove from body compromising on enamel. So how to prevent that?
I will show you that during the demo. I believe that will be answered during the demo. Okay, I see another question. How to prep margins in no or minimum prep without getting undercut? Again, no prep is frankly, you will actually end up with a slight bump when you go for a no prep veneer, because then the lab decides where to keep his margins. So you will end up with a slight bump. It's always better you give a minimal prep veneer. It could be a 0.2 or a 0.3 mm prep veneer utilizing the enamel. Also, what you do when you do a minimal prep veneer is you take away the surface of the enamel, which is aprismatic now. The patients use a dentifrice every day, which has a lot of abrasive. So you just take away that layer and you will now have a veneer that seats in positively. So you have a positive seat. I will anyways take up the prep in the demo now, and most of these will be answered. The next, if a veneer debonds, how to refix the same? So ideally speaking, if a veneer debonds, you should send it back to the lab for them to remove the cement that is left over on the inner surface of the veneer. Because if you try to remove that with say even a burr, you might lead to cracks. When the lab does it, they use a sandblaster, the lab sandblaster, and they will sandblast the intaglio surface, remove all the cements and send it back to you. Now, when you have it back, you follow the same protocol. You follow the hydrofluoric acid, followed by the phosphoric acid, silent coupling agent, bond, and then use a light cured veneer cement. On the tooth surface, you will use phosphoric acid, 38 or 37%, 30 seconds. After that, use the bond. If you have dentine exposed, then light cure the bond. If it is only in enamel, you do not need to light cure the bond. You can go ahead and marry your veneer with the tooth. How to bond lithium disilicate? I believe I've just told all of those steps. So the first step is on the intaglio surface to use hydrofluoric acid, then use phosphoric acid to remove the salts. Then you will use silent coupling agent. Then you will use a drop of bond. Again, don't light cure the bond on the veneer surface at all. Use veneer cement. On the tooth surface, you follow the same tooth surface protocol. In a diastema cases, up to what space limit can veneer be done? I believe there is no space limit to do a veneer, but you will have to look at the overall picture. And that's why the mock-up becomes very important. So when you ask the lab to give you a mock-up, you put it inside the patient's mouth, look at the mock-up, take some videos like we did, take some photos and videos. Now sit and see if that is looking harmonious with the tooth. If it is not looking harmonious with the face, see, ultimately the smile begins with the eyes and finishes at the lips. So you will have to look from ear to ear, and if it is harmonious, you go ahead. If you feel it is not harmonious and the patient thinks the teeth are looking too wide like Bugs Bunny, then it is always better to again refer to ortho, get the teeth into the correct alignment, and then you can look at doing veneers if ortho cannot close the gap entirely. Again, there are limitations to ortho also. It may not be able to close the gap entirely. Let me just check if this is working. Yeah, can you see the model? Just take it down. Yes, I believe our patient is ready. Okay, so let us begin the live demo. I will first show you how do we do a ProTemp mock-up, and ProTemp mock-up. I'll take that question after the demo. I just need to start from here. Okay. So just do a ProTemp mock-up and then prep through that mock-up. Let's see how this is. I will first show you my. Okay. So let me first show you my veneer kit that we generally have ready. Just turn the camera either way. Let me see it. Okay, so this is our patient for today. She has come for a better smile. Okay, so just imagine that you've done the smile designing procedure. You have set to. Now, for one moment, just think that this is the mock-up that you've got back from the lab. Okay, so this is the mock-up that the lab has sent to you. What you will do on the mock-up? Can I have Putty? What you will do on the mock-up is create something called as a Putty index. Putty index. So this is called a Putty index. I will show you how you prep this, how you make a Putty index. So this is a Putty index. This will be used to transfer the ProTemp into the patient's mouth. ProTemp can be done for two things: one for patient approval and acceptance, and second to prep through that mock-up. Okay, so let's first take some Putty and create a ProTemp, create a Putty index. So for today, we shall be using the 3M soft putty. You can use the intraoral putty also, or you can use silicone. I will be using the 3M soft putty, 3M SP soft putty. Take one scoop out of both. Can have one scoop of both here. One scoop both, start mixing. Now, you can also use the light body to create the index because the light body will record it deeper. Or let me show you a technique that I follow. We call it the two-step putty technique. So the same putty will be used in 2 steps to create a very nice, what do I call, impression, which will be very close to the tooth surface. Now, you cannot do this or you cannot follow this technique to take a final impression. It is only for the putty index. So what I have done is I have divided my putty into 2, one small and one large. Let me first place the small part onto the tooth surface, merge it nicely, the small one, the smaller layer, merge it onto the tooth surface, just gently tap it onto the tooth surface. Now take the larger one and further push this. So I'm pushing the first one with the large one again. So both of them are mixed at the same time, not separately. So what this does is it adapts the first one very closely onto the tooth surface. So this is the 2-step putty technique where you get a very close adaptation and you do not need a light body. So why is close adaptation important? Because the closer adaptation that you get, it will be easier for you to trim off the ProTemp. The ProTemp will be very thin in that area. So you can just remove the little excess that the ProTemp might generate. So this is how your putty index should start to look. You can see that it is in 2 layers where my upper layer is pushing the lower layer inside onto the tooth surface. On the palatal, you do not extend it too much. Now, if I'm looking to do a putty index, in this case, we're just looking to do the 2 centrals. So my putty index extends from the premolar to the premolar. But if I'm looking to give the patient a mock-up from the premolar to the premolar, then I should start my index from the molar to the molar, because 2 sound teeth are needed, which will not be prepped for your index to reseat. So let's see, this looks to be set, and see how closely you can see that this has pushed it onto the tooth surface nicely. You have a very close adaptation. In fact, you can see that there is a little defect there in the class 3 prep. You can see that it's just breaking off, and even that has been recorded very nicely. Now, to this, previously, what we used to do is we used to take a knife and cut off exactly at the cervical portions. But when we used to do that, it used to make the putty very fragile there at the cervical third. We no longer do that. I just like to create a little notch for me to understand where my incisal or where my central midline is. Just that, just a little notch, so that it will be easy for me not to be finding and reseating it directly. Just that little notch to guide me where my central midline is, basically nothing else. So this is my approximate midline. Just that little notch. Which mode is this? अब नहीं हो रहा ना? Okay, I just need to adjust the video settings. Okay, so now that's done. Great. Okay, now it's not happening, right? Perfect. So I just like to create this notch so that my reorientation is very easy. Now let's pick the protem. Okay, let's pick the protem. And I will start loading the protem. Give me the protem. So protemp is a material from 3M. It fits onto the 10:1 gun. You need a separate gun. It comes in an Automex pack. You just disperse a little material outside and now start to load. So if you are looking to do it from the lateral to the lateral, you start to load from the lateral. Load it onto the facial surfaces. You don't need onto the palatal surface much. Load it just onto the facial surface. You can go till the canine if you want to. Just to show the patient the smile design, you take this, take it into the patient's mouth, and like I said, reorient it. See how my protem just gets set there. Now the advantage with protem, it's a bisacral material, it sets very quickly. And if there are any spots that are not binding properly or just tear off, you can add some composite there and it will bond. So just to check whether it is setting. So you can take off the excess like that also, but don't do that. You can tear off a little more. This will be very snugly fitting to the tooth, so that's okay. So look at that. You have your protemp index in place. You can show this to the patient, but before you show it, just remove these little excesses. Just take a 12 number blade and run it down very nicely on the cervical third, and these excesses will just come off. It will not stay. These are not meant to stay there. There is no excess, true excess. That is just protem that has overflown. Just take the 12 number blade and just run it off so that all these excesses go away. You can now take the patient photos, videos, and show them how it will look post your prep is done. I did not push the putty completely to show you that this is a putty index to show the height and everything. So say the patient approves now, and the patient says, yes, doc, I approve the smile. Please go ahead and prep the tooth. So what I like to do is create two indices. I like to create two more putty shells. Okay. Now in the first putty shell, I will cut it first along the tooth surface where I want to do the prep, something like that. So, pardon me. Yes, it is ideally different. I'm just showing you that this here, and you can divide it into 3 layers. So this is the cervical third, this is the middle third, and then is the incisal. So you can divide it into 3 layers so that when I do the prep afterwards, I can just pull this and see if I have enough clearance. Okay. Now the other index is what I would slice exactly horizontally to see the overall prep. Once the prep is done, to see the overall prep, this is exactly sliced in the horizontal area. There, exactly into the horizontal middle third of the tooth, middle part of the tooth, so that I can see if my prep has enough clearance in all the 3 planes. So these are just as my guides, which will help me in my prep afterwards, not right now. Okay. And now let me introduce you to the veneer kit that I have, or the veneer kit that I generally use and make. The first is a 0.3 mm depth cutter. It's called DW11 and DW12. Again from Money. 0.3 mm depth cutter. Next is a 0.5 mm depth cutter. The third burr that I'm putting is the SR11. SR11. The fourth burr that I'm putting right now is the TR13. The advantage is the tip of both. This is around 1 mm and this is around 1.1 mm. So I will maximum prep only to half of those. Then I use the TC11 if I'm going through the contact. I don't want to damage the adjacent tooth. And finally, just to remove any enamel interferences which are at the cervical end, I use the end cutting burr. So this cuts only at the end. This is called the EX18F. So this is the only burr that you will need 99%. DW11 and DW12, that's a depth cutter 0.3, depth cutter 0.5, SR11, TR13 in red. So you can understand I'm coming from the coarse to the fine. This is when you're going through the interproximal areas just to cut. And then you use an end cutting EX18F. I also like to use the SR11 in F, but unfortunately this burr is not available in India. So that's why I did not want to introduce this, but the SR11 can also be used in red. Finally, to polish the restoration and to remove any denting enamel overhangs, I like to use the brownie point, and the brownie point will be finally used to polish it. And at the last, if you want a super polish, you can use any composite polish. So let's start the prep with a 0.5 mm depth cutter. No, for final polishing, I like to use a composite polisher, not a yellow ring burr. That's why we just stopped at So the first thing that we will use is the SR11 burr to give the incisal depth cuts. So imagine this is the tooth, SR11, like I said, 1 mm in thickness, width, insert it completely in horizontally. Slightly more because you want at least 1.5 mm of clearance. So SR11 completely in and slightly more. That's 1.5 mm of clearance here. You can take a perio probe and check that. Okay. The next is when you will use a labial depth cutter. So start off with a 0.5 mm depth cutter, which you will use in the middle and the incisal. 0.5 mm depth cutter in the middle and the incisal. Again, even the depth cut works in 2 planes. Look at that. Just the middle and the incisal. 0.5 mm depth cutter. Don't prep more than that. 0.5 mm depth cutter, and we will use a 0.3 mm depth cutter for the cervical. Remember, the enamel on the cervical is very less. So I move to a 0.3 mm depth cutter, sticking to the 0.5, but here 0.3 in the cervical. So 0.3 mm depth cutter at the cervical. Now, once you are done with the depth cuts, take a pencil and mark the bottom of those depth cuts. Mark the base of these depth cuts. What this helps you is the fact that you will not prep any further tooth structure. Your final tooth prep will be beyond that, above that pencil. At this point, you can just peel off the protem. Protem job is done. You no longer need the protem to stay onto the tooth. You can just peel it off. You can just peel off the temporary protem from there. Now, you will take the Sr11 Bur again. If it's in the mouth, you can take the Sr11 because it's a coarse burr. But here I'm starting with the TR13. Now the TR13 will work in two planes. Okay, let me show you with the Sr11 because that makes it easy to understand the two planes. Somebody asked me that they get an undercut. So let me manage the Sr11. So the Sr11 burr, now you will tilt the burr in two planes. You will not use the burr in one plane and then you will create an undercut. See, the biggest problem that I understand people doing is the fact that they will start to create a finish line. So you don't need to create a finish line. The geometry of the burr is such that it will create a finish line upon itself. Just give it that time. So first you take the incisal edge and reduce it. Just join the three lines that you've created. Okay. Once you have that, just leave it. The final finishing, you will do it with a disc. Now, see, the length of the burr is almost ideal for the entire tooth surface. So start off with the cervical area. When you're prepping there, you will eventually touch a little part of the cervical and the middle. Now tilt the burr again, so that when you're prepping on the incisal aspect, you are not touching the cervical portion. Use the entire length of the burr, please, and learn to tilt the burr. Then you will not create undercuts. If you prepare like that and then like this, then you will definitely create an undercut. When you have a burr as the line of your parallelism, you will never create an undercut. Go around the interproximal areas and stop there. Just merge the incisal aspect now. See, I'm not trying to go beyond what my pencil line showed me. Just go along and stop there. Make your burr straight when you are coming out. Let's go on to the other side again. Give me a 00. You will never have an undercut when you prep like this. You just need to merge and marry the tooth surface entirely. Prep using the entire length of the burr. The burr is designed to give you a finish line. Don't try to create a finish line. Let it get created by itself. And this area, remember, you need 0.7 mm. So prep slightly more into the incisal part where you will have maximum merging of your ceramic, and also you need aesthetics there. So remember, you are following the two planes. Look at those. Follow the two planar reduction. And at this point, once you have done the gross prep, stop and insert the first retraction cord. Your first cord will be inserted right now. Say you are using a 00 retraction cord in this case. So you take the 00 retraction cord. You take the 00 retraction cord. I like the retraction cords from Ultradent. They are frankly the best that I have used till now. Take the retraction cord. Take the cord packer. This is the Yardley cord packer from U3D, non-serrated. Insert it through one line angle. Once you've done that, just take it along the long axis of the tooth. Trust me, it is easier on the mouth than in the model. But just put your cord packer along the long axis of the tooth and pack the cord in gently. From one line angle to the other, push the excess cord to the palatal side. If you are extending it, you can extend it onto the next tooth. If your prep is going on to the next, you can just extend it like that along the next tooth also. Or you may just cut the cord right there. Again, the beauty of the gingival cord packer Yardley that I like is the fact that it's a double-ended and it's a single instrument. You don't need a pair of cord packers. It's a single instrument that works very nicely. Okay, once this is done, you see now the finish line is much better to be viewed. You can actually see it very well. At this point, I'm looking at finishing my prep now. So almost my veneer prep is done, frankly speaking. I'm just looking at finishing my prep. Can I have the Zechariah, please? So I like to protect the gingiva when I'm working on finishing my prep. I just like to protect my gingiva. This excess composite or the pro-temp can just be pushed in and it will go away. Okay, so I like to protect my gingiva and I like to use something called as the Zechariah gingival retractor, because this will allow me to create an ideal finish line without the fact that I am going to damage the gingiva. Because if I start to hit the gingiva with a diamond point, it's going to bleed like crazy. And if it starts to bleed, my mind just goes to control that bleeding all through the prep rather than looking at finishing my prep better. You can just hold it like that. Now you can shift to the TR13 burr now. So the job of the SR11 is done. You don't need a coarse burr anymore. You are looking to finish everything now. So move to the TR13 and see how we work with this. We just take it along the cervical again, run it along the tooth surface. Never try to create an undercut. If you lift and use it, you will create an undercut. Please run it along the tooth surface. Go on to the other side. And you can go ahead and finish your prep. Just merge everything very nicely. When you are using proximally, you can move along with the gingiva, the Zechariah. It will move along where you are and retract the gingiva very well. Look at the prep. Almost done. All I need to do is just take off the undercut. I just need to merge everything nicely. And onto the occlusion surface. So this is a incisal overlap design. So we are just going to smoothen the occlusion surface flat and slightly create a bevel. One bevel here, which you've created by prepping a little more tooth structure, and the other bevel would be at the junction along the palatal surface. I'll just show that. So just let's create this. Now you can use a disc. Occlusion, it's like that. It's just flat there. I'm still not finished. I'll show you the occlusion. What I like to now use is the 3M disc. People who know me know my love for two things. One is the disc and the other is a brownie. You take a disc and just flatten that off. The advantage is you cannot cause any damage to the enamel with a disc. All unsupported enamel will be taken away. Now when you do this, slightly angle it around 10 degrees onto the palatal surface. Why? Because the enamel rods are oriented like that. Enamel rods are oriented around 10 degrees to the palatal surface. Something like that. Just an angle, a little bevel, nothing more. So you're not looking to create a finish line there. and in the proximal area, just create some separation so that your material can go in and record properly. Just create a little separation using the disc. There is some protem there, so you just need to create some separation using the disc. So when you have a separation like that, the material can go in comfortably. Your light body can go in comfortably there and will be able to record it better. That's the adjacent tooth and some protem. That's what I was trying to do. But anyways, when you have, so there your prep is almost done. You can now again take the SR, so the TR13, and just finish off the proximal margin. So this is a simple veneer prep where you are not breaking the contact, but there will be instances where you have to break the contact. And how do you do that and stuff? We will teach that all as a part of the program. We have an indirect web live program that's coming up, which is for 4 days from 23rd to 26th of March. It comprises all indirects, including veneers, posterior bonded restorations, and everything. We already have about 40 registrations done for that. So I will be happy if few of you or almost all of you can join us, and it will be a great session there. So once this is done, finally, we use the composite polisher to polish the. I'm just trying to remove that little protem that got stuck. Don't worry, it will not get stuck like this in the mouth here, because there was composite on the next tooth. The protem just got stuck. So that's your prep. Someone wanted the occlusal. See how the occlusal is slightly beveled to the palatal surface, but that's your prep from the occlusal. Now you can take the composite polisher and just, so even before the composite polisher, I like to take the brownie. Now the problem with the brownie is the design is not apt for your prep. So what you can do is you can modify your brownie by just running it around the burr. You can take the burr and put the brownie along it. So that's the burr, put the brownie. It will just modify the brownie as you require ideally. Give you a little more working surface. So you can take the brownie now. Just so on the typo, it will not make a huge difference, but inside the mouth, you will realize that all enamel undercuts are gone, all unsupported enamel is gone, and your prep looks so much more finished. Finally, you can use the composite polisher, any composite polisher, and just polish the prep. Remember, it's an adhesive based prep. So you will anyways etch it and micro etch it on the day of bonding. But right now you want the light body to record the crypts and the depths very nicely. And that's why just polish it nicely with a composite polisher and your prep is done. Now let's use the depth gauges that we had made to see whether our prep is enough or you will need to prep a little more. That's where the depth gauges come in handy. So let's use the first gauge. Is this the first? I believe this was the first. Let's use the first gauge to see if I have adequate clearance. Look at that. Now, if you see, give me a probe. If you see, from the occlusal or from the incisal, also you can see how this is angled slightly. So from the incisal, we have 1.5 mm of depth prep. Let's see. Yes, around 1.5 mm. In the incisal edge, I have a more prep, almost a 1 mm prep there. Yes, ideal. Now, when I go down, a 0.8 mm at the body, and when I go down further, it's just a 0.3 mm prep. So that's how my prep is gradient. And you can see that it's a beautiful. Let me go closer. See how the prep is so much more better. So when you have these, you can cut it at multiple tooth surfaces and you can place them one after the other. So if I had to check the other side, I would have placed it like this. I have one more cut, so I would be able to see the adjacent tooth also and see how much I have reduced. So you can have multiple indices made, and that helps. The other index that we made, let's use that. So just to give you an example, the other index that we made, we can cut it in the incisal, pull it off, middle, pull it off, and incisal, cervical, middle, and incisal, and you can see all three angles as to how the prep is. So that's how smooth my prep looks just before I am looking to make an impression. Now, if my margins are not clearly visible, I will use a second cord. I will use a second cord when my margins are not clearly visible, and that will be a bigger number cord. That will also give me horizontal retraction for my impression material to go in and record. Okay. Okay, let us get back. Okay, somehow this refuses to show back my face. No, it shouldn't. Yes, great. Okay, the instrument's name, which instrument? The Zechria retractor? Yeah, that's the gingival retractor Zechria from Dentsply. Or you have the Yardley cord packer if you're asking about the cord packer, that is from Ufridi. Okay, so I was where here, yes. How to debond temporary, which is cottage before permanent cementation. You can just pull it off and it will come off 99% of the times. Sometimes you may have to cut through interproximally and remove the protem. So protem is very fragile, it's very thin. It will chip and break. There will be cement left behind or some protem left behind, which you can polish using the composite polisher or the brownie. The advantage with the brownie is it will not cause any damage to the enamel, and that's why it works very well. Okay, the mock-up and the cast is different. Yes, the mock-up and the cast is different. The mock-up is what you get back from the lab. I think I have shown the occlusal view. Yes. Any tips on shade matching? Well, it's almost a full session that I take on shade matching and the PG protocol. I would love if you guys can join me when we are taking the 4-day prep, because that includes shade matching. And trust me, shade matching is not a very simple protocol, that as we might like to call it, because we like to do it in a slightly different way. We call it the PG way. And I have a PG color chart that we've made, and that color chart will help us in sticking to the lab. We removed all the temps, and how does it prep? How does it help in prepping through the prep? Because when you prep through the temp, you are only prepping to that depth that you've created, right? Now that depth is only 0.5 mm. If I start with the depth cutter directly onto the tooth, a 0.5 mm will be beyond the enamel sometimes. So eventually there might be an additive prep. So 0.5 mm that you prep plus 0.3 mm that the lab needs to add. So your veneer is thicker unnecessarily, and yet your job is not done because you've not conserved enamel enough. Perfect.
Thank
you.
Any that thing repetition of all the instruments names? One more.
Okay, so the instruments that I used, you want the instruments or the burrs that were used?
Yeah, burrs. She means burrs.
Okay. So the burrs that were used were depth cutter 0.3 and 0.5. 0.3 for the cervical, 0.5 for the incisal and the middle. Next, we used the Sr11 Bur, which was the blue banded burr for the gross prep. Next, we used the TR13 Bur in F or finishing or the red, because the TR13 in red gives you the finished part. The red is always better to finish. And then if I have to break the contact, we use the TC11. It comes in blue. So you can use the TC11 if I have to ever break the contact. And I like to preserve the contact, but in some cases you are forced to break the contact. And for the finishing, after that, we have the EX18. In case there are any undercuts onto the cervical edge, you can use the EX18. And then we use the brownie point, which was from Shofu. Also, the brownie was modified according to what we needed it to be.
Fine. It was a wonderful session. So let's wait if more questions are there. We can have more questions.
Yes. Another 10 minutes.
Still 5 minutes to go for the meeting. Any more questions?
Yes.
You can come on the video and ask directly. If anyone is having any question, please go ahead. Yeah, one more question is there. YouTube link. Yeah, okay, go ahead.
Okay, what happens if we place the veneer and finally we are not happy with the final result?
You will have to cut and remove the veneer, which is a task. Frankly, it's a big task to cut through the veneer and remove it. But yes, it can be done.
So, I mean, it would not be possible to cut with the normal burrs.
No, you can cut it with always use, so even with zirconia, I see this little fad where people use a coarse burr to cut through zirconia. No, you need a fine burr to cut through ceramics. Ceramics are finer particles. You need a fine burr to cut through ceramics. So use a red ring burr and then cut through right in the center and then split it into two. Always better, because ceramic will crack. Your tooth will not. So you're utilizing the advantage of the ceramic where it will crack, whereas the tooth will not. So I will create a line at the center and in the incisal edge. Remember, incisal edge, I have reduced by 1.5 mm. I will engage the groove in the incisal edge and break it into two. The ceramic will inevitably break and come out. Because if you're trying to grind it down, you cannot notice a difference between where the ceramic ends and where the tooth begins, because your tooth, the cement will also be of the same color.
Okay. Fine, thank you.
Most welcome. Can we get YouTube link? I think yes, it will be there. In what all cases would you do the incisal lap preparation? Very rare. When I already have a composite, say patient had a previous composite veneer and it was overlapping, then I will have to use that overlap. Second, if the patient comes with a fracture which is oblique, which is extending onto the incisal surface or the palatal surface, I will have to unfortunately go with an incisal overlap. Otherwise, at the margin, I might have dentine left. At the margins, you cannot have dentine. You will have to go back and grab enamel more. Please share once the details of the online course. Yes. Okay, let me share my screen. So, that visible? So this is the online program that we have. It's an indirect web live. It will have 4 days. Is it scrolling? Yes, it will have 4 days. The cost is 11,999, but for today and tomorrow and people who are logged in here, you will get the same at 8,999, 9,000 rupees. You can contact Dr. Sudhir and he will help you out. And you will get the same at 8,999 for the next 2 days. Day 1 and day 2 are on anteriors, where everything is discussed in detail about different types of preps, shade map and lab color chart, bonding setup. You have videos that will be played and plus live demos. Day 3 and day 4 are for the posteriors, where we speak of vital versus non-vital teeth. You speak of immediate dentine sealing, deep margin elevation, and inlay prep and onlay prep and overlay prep, which cusps to cup and which cusps to remain. And Those are the account details right there, or you can contact Dr. Anshu, Dr. Sudhir, or me. There are 2 numbers there. You can contact Dr. Anshu or me, or even Dr. Sudhir can help you out. Dr. Sudhir, you need to unmute.
3 to 4 people have already joined for the
Okay.
So if anyone else is willing to learn, this is very small session and very less time is there.
Yeah.
But anyone wants to learn more, definitely you can contact any one of these people, anyone, anytime. One more question is there.
Okay. Yes. Shade selection. Will the shade of the bonding resin affect the color of the veneer? Technically speaking, it will if it is less than 0.3 mm in the overall thickness. But any veneer which is more than 0.3 mm thickness will not be affected by the bonding resin. Having said that, initially, please use translucent veneer cement only. Do not try to play around with the veneer cement and try to play around with the final protocol. Just use translucent veneer cement, because now you have ingots good enough to mask the discolorations. We used to play around with the cement shades a lot, but that was when we did not have good ingots. Now you have good enough ingots and good enough labs. So just use a translucent veneer cement. Is lithium disilicate always used as a veneer? 2 things there. Lithium disilicate can be used as a veneer, can be used as a full crown, can be used as a CAD/CAM crown, can also be used as a 3-unit bridge in the anterior, no for the posterior. Now, is veneer only of lithium disilicate? No. You can use feldspathic, you can use lucite, and you can use lithium disilicate. Also, you can use indirect composite, like I told you. But lithium disilicate is the most commonly used material to do veneers, because 1 of its strength, and 2 the fact that you get CAD/CAM blocks also now, so the strength is pretty high. Any post-op instructions? Well, I frankly give no post-op instructions except for biting on ice, biting on chicky, and biting on bones. Apart from that, let the patient enjoy everything that they want. When should first follow-up be? After 2 weeks. After 2 weeks, always have the first follow-up. Take X-rays, see if there is any resin left out, see if the gingiva is inflamed and bleeding. There might be some composite resin that has gone inside the gingiva, and that might be troubling the patient. Apart from that, if the patient has any pain or discomfort, then you will always schedule the appointment at priority.
Fine. If all the questions are done, I request everyone, can you please switch on your cameras so we can take a picture and finish this meeting and move on to next. Can you please switch on your cameras? Everyone come on the camera, and many people are thanking you for this wonderful session. A lot of messages are there thanking you, and this is really a nice session from you. Thank you so much.
Thank you.
This, yeah, fine. Okay. Thank you everyone for joining. We will be having next session very shortly. One is on 21st of March, and more sessions are coming. So whatever sessions are there, we will be sending you a link, and we will be posting it on YouTube, and link will be sent to you on WhatsApp. So thank you for joining. Thank you, Dr. Pratiek, once again. We will be giving you.
Thank you so much, everyone.
It will reach you very shortly. Thank you so much.
Thank you.
We can end this meeting, okay?
Yes, we can.
Fine, fine. Okay.